So let me introduce the great Dr. Brian O'Hay.
Thank you, Pat.
Thank you, sir. Please.
Oh, so you're going to sit here with me. That's nice.
Yeah, I'm sitting here with you. I know you were watching before, so you know exactly
Well, thanks,
how it
Pat,
goes.
and thanks to all our volunteers, organizers, and sponsors. Really appreciate all the efforts they all made today. And thank you all for being here. You know, it's a hot day, so there is certainly cooler in here, but it means that you have trust in Stony Brook, and you trust and believe in Stony Brook. And I think there's every reason to trust and believe in Stony Brook. So thank you for sticking it out and being here today. So the topic is breast cancer update, which is an enormous topic. What I thought I would start to do is to start with breast cancer screening, since October is Breast Cancer Awareness Month, right? So there's some controversy and debate among medical societies when a woman should begin her mammogram. Different societies have different recommendations. But I think for an average risk woman, she should know that she should begin annual screening mammogram at age 40 and annual thereafter. There are other groups that would say differently, but I think that's a good baseline play. The important part of that is if your mammogram is considered dense in the report, not that your doctor told you, because many doctors just say it's dense, but if your mammogram report says dense, you should also get an ultrasound. So those are the basic things to remember, and it's now New York state law. I think there are 40 states in the country. It may have just become federal law that a woman has to get a letter in the mail saying her mammogram is dense so she can discuss additional opportunities with her doctor, like an ultrasound. So that's a very important thing. Some women who are high risk may be eligible to begin earlier. We generally start daughters of mothers with breast cancer 10 years younger than the mother's age. So if a mother was diagnosed at 45, her daughter would start at 35. And that's pretty standard. You rarely start screening younger than age 30. And some high-risk women are also eligible for an MRI. Some women who are higher risk can have MRI screening 6 months after the mammogram every year. So it's very variable outside of the normal population that you start at age 40. So each woman should discuss with her physician, you know, what's the best program for her based on her history. And that's sort of an outline of screening.
So you nailed it on the head. It is a federal law. It's being implemented in the next year or two that we have to notify the patient on the density of the breast, which this was a great segment into this because we ran out of time with Dr. Steiger, so we didn't get to talk much about the density and how that could obscure possible malignancies in the mammogram.
Yeah, so those stories of obscuring, it's still very important, but they were generally from the older mammograms where they were more likely to hide things and the ultrasound would have found them. 3D mammograms are much better. So we don't know for sure with a 3D mammogram if you still need the ultrasound, but it's still, we recommend it until somebody proves that you don't need it. So I don't want you to go, when you get a 3D mammogram, you're having a really good study. I don't want you to think it's useless, but the ultrasound can only help if the breast is dense.
Great. And you being the chief of breast surgery here at the Cancer Center, you've seen it all. And you've been in the game for quite some time, I would imagine, with you and I similar with lack of hair on the top of our head. Me, more genetics, you with wisdom. But tell us about what you see most of and what's your, say, bread and butter, if such a thing exists in breast cancer. And, you know, what are you seeing a lot of in the Long Island population that comes to see you?
Yeah, so let me just maybe take a little angle off of that. So breast cancer rates are pretty much the same. They're not going up or going down. So the same number of women per population on Long Island and elsewhere are getting breast cancer. But what's improving is the survivability of breast cancer is clearly improving, and mortality rate is decreasing when you look at a large population of women. And that's no doubt a result of screening, so early detection, improved survival. Treatments are so much better. So there were things that weren't treatable before that now are treatable for survival. So that's an added benefit and an added result or cause for the reduced mortality. The other thing that we're starting to see, and thinking about it myself, because Newsday wants to do a piece on this next week, is that we have some people in the population, not a large percent, but they have the BRCA gene or some other gene that genetically predisposes them to breast cancer. And someone with the BRCA gene can get a serious breast cancer that could be harder to treat. in identifying those people in advance and giving them the opportunity for risk-reducing surgery, we can move those patients off the table in terms of getting breast cancer and maybe not faring so well from breast cancer. So I think moving a small percent of the population at high risk off the table, meaning if they have risk-reducing surgery, they don't get breast cancer, I think that can also contribute to a lower overall mortality in a large population of people.
So thanks for bringing that up. We spoke earlier with oncologist, and we spoke about removing some organs post-menopause that could save them from, if they were high risk, for ovarian cancer, which was also a BRCA mutation. Now, speaking of breast cancer, it's more, I feel like, in the limelight. You've seen many celebrities get the risk-reducing surgery because they had the genetic mutations, first-degree relatives, et cetera. Have you had many patients, do they come to you, or not yet at that point, but what's your stance? Is it affecting the patient in a negative way if they were to get, say, a double mastectomy, for example, prior to anything showing up malignancy-wise?
Well, people who have the BRCA gene have a dramatic risk of breast cancer. It could be as high as 60 or 80% lifetime. So they have a very difficult decision to make, and it's not an easy decision. But in doing risk-reducing surgery with reconstruction, we can still make them look nice. They can bring that risk down to 1%. So it's still, again, it's a small population of women, but you know, it sometimes can be life-changing in a positive way to lift that weight off their shoulders.
So a woman will get a mammogram, and doctors like Dr. Steiger will read it. She'll get a diagnostic. If it's a BI-RAD 0, she'll go for a biopsy. And the radiologists are doing the biopsies, and if the biopsy comes back malignant, now they're transferred into your care.
Right.
Is that the stage that
Yeah,
they're now
I think that's
transferred
pretty
to?
much the order of things. And I think the thing to focus on, because we don't have all that much time in thinking about this, and it's not just for breast cancer, but it's all different types of cancer. There's a national movement and trend towards de-escalation of treatment. And what that means, reducing treatment density and reducing treatment intensity without sacrificing efficacy or longevity. De-escalation. Doesn't mean it's for everybody. Nobody's de-escalating in a dangerous way. But the best example of de-escalation is in the 1950s, where everybody had a radical mastectomy, and now many women are able to have a lumpectomy with radiation. So that's been less treatment density, less treatment intensity, de-escalation of surgical treatment, and efficacy and longevity has not been affected in a negative way. So there are many different ways in breast cancer treatment when they come to see me after the biopsy where we discuss opportunities. There's a particular opportunity nowadays in women over the age of 70 for de-escalation from a breast cancer point of view. There is some evidence, you know, when a woman usually has breast cancer, we check the lymph nodes in their armpit. We usually check, most of the time cancer hasn't gone to the lymph nodes, but we do something called a sentinel node biopsy, which is an armpit operation that still removes a couple of lymph nodes. It seems to be with the routine type of tumor that occurs in an older woman, a woman over than 70, there's a national campaign now that doing even the sentinel node biopsy might not be needed. And it's not going to really add information. And there's no reduction in survival or longevity. And in fact, the national campaign says do not routinely do sentinel node biopsy in women over the age of 70 that have estrogen-positive tumors. So another step towards de-escalation, right? Less treatment density, intensity, without compromise for longevity. So there are many different ways to do that, and I think for anybody in any type of cancer, when you're sitting, or a family member that's not here today, when you're sitting in front of your doctor, you ask them, are there opportunities for de-escalation? It might be no. It doesn't mean everybody can get by with less, but you should at least ask the question, are there opportunities for my mother who's 80 or my father who's 88? Are there de-escalation opportunities given the situation we have?
So those are great points, because the common theme amongst all the speakers are collaboration. And similar to what you're saying, in the past it might have been you doing a radical surgery many years ago, but now it seems there's more collaboration with a radiation oncologist for, you know, better pinpoint treatment that doesn't, say, cause as much adverse effects or damaging tissue to the patient. So speaking on that, where do you see this going, and where do you see any innovations maybe that we're working on at Stony Brook that you're dealing with firsthand? For example, in GI, Dr. Sassone's doing more robotic surgery and an aerosol chemotherapy for peritoneal metastasis, as he spoke on before. So where is this heading now in breast cancer?
Well, one example was the de-escalation of armpit lymph node surgery. There are some patients who are over 70 that have lumpectomy who might not need radiation, with a little bit of a higher recurrence rate. That doesn't appear to affect survival or longevity, so we're trying to isolate people who could be candidates for that. So in that regard, the therapies are dramatically improving, and we're able to run tests to see who needs the treatment or not. You know, for many, many years, almost all women, even with stage 1 breast cancer, received chemotherapy even if the lymph nodes were negative. But then became a test called an oncotype, which can be run on the tumor, not so fast. You sure I need chemo? Let's check the oncotype score, and if the oncotype score is low, then that's a woman who used to get chemotherapy who no longer needs chemotherapy. So another opportunity for de-escalation. From a surgical innovation point of view, we've always worked very closely with our plastic surgery colleagues after a mastectomy with reconstruction. So they'll come in and help us reconstruct a woman after removing the breast. We're working more and more with the plastic surgeons even after lumpectomies, and we're finding women who are on the larger size breast-wise, who maybe have always wanted a breast reduction in their lives and never really got to it or weren't qualified for it, that we're able to offer them that in conjunction with a lumpectomy. So that really seems to be the newest thing we're doing as a team, where, you know, the downside is you have to have this lumpectomy for cancer. You're going to be okay. Don't worry, but we can also maybe give you some enhancement, maybe something you've always wanted in your life to help you in that regard. So they get a breast reduction and lift at the same time we do the lumpectomy. So that's not true for everybody. You have to, you know, it's a size issue and a tumor size issue. But that's a good example of collaboration. And again, taking sort of a not so great thing or a bad thing and trying to make something good out of it. And patients seem very happy when we're able to do that together.
Wow. And so, of course, everything is by an individual case-by-case basis. What works for one is not always going to work for the other. And now when you do collaborate with a plastic surgeon to either reduce or lift, or is it done the same day in the same procedure?
All together.
Yeah. So the patient just one time has to go under anesthesia and everything's getting done?
Yeah, the woman in that scenario, again, this is not for everybody, but you know, there are selected patients who are excellent candidates for this. They'll wake up and look at themselves as if they had breast reduction. Right. And at the same time, they don't see the results of the lumpectomy. The lumpectomy is done internally, and then the breast reduction is done around that.
Right.
Yeah.
So, you know, with breast cancer and lumpectomies, mastectomies, single, double, you know, it's very different from any other organ, because when you get a tumor removed from an internal organ, obviously nothing visibly changes in the patient. Now, dealing with breast cancer and breast issues, it's a much more personal feel to it, because the visual effect is there, and the woman could go through such mental anguish because she could wake up and now a part of her is missing. Even if it's healing her, a part of her is gone. And so I've met women who've decided to undergo reconstruction. I've met women who have not. And then they would get, say, form-fitting bras and et cetera, so that visually they would look as they did prior to the surgery. So you're not only dealing with, hey, life-saving procedures and you know, tumor removals and cancer removals, you're dealing with a patient that's could be mentally going through a lot during this hard battle of their life.
Well, I think you're right. I think all women are going through a mental battle, regardless of what operation they have. Just when they're told they have cancer, it's a mental battle. So I think we see it as our responsibility as surgeons and as a multidisciplinary team. Of course, you can't practice breast cancer in separate silos. So you have to have everybody working together, constant communication, because it is a multidisciplinary disease that requires multidisciplinary input. But I think that the important thing is to keep all options on the table. And when we come to work as surgeons, we try to, is there a way that we can save this woman's breast? Is there a way we can save her breast and make it look good And then we start with that, because we don't know what a woman wants herself. So we start with that. And then it's up to a woman to decide in her own mind, the way she sees the world, in her own life, that she's willing to pursue that path towards breast conservation and the steps that might be involved, or in her own mind, she would feel better having a mastectomy with reconstruction. But we always start and come to work every day to think of ways that we can save a woman's breast, but we also understand it's not for everybody. And
Sure.
it's the woman herself has to make that very difficult decision herself, because everybody's life is different and everybody sees the world differently through different sets of eyes. So ultimately, it's up to a woman to make that very difficult decision, and we're here to help guide that decision.
So once again, touching on the point of collaboration amongst not only different doctors, but doctors and patients. And you're I would call you, the leader of this great group. For those of us who don't know the rest of the team, who else are breast surgeons in the Cancer Center that,
Yeah, well,
patients
first of all,
can turn
it
to?
really is a team. I mean, I'm the oldest. I guess that means I'm the leader if I'm the oldest. But we've had a really great run. I've been here, 27 years, and everybody that came on board, our nurses, our senior nurses, our nurse practitioners, everybody came on board like 20 years ago. And normally there's turnover. Someone will take a new job after 5 years. We hire somebody new. Someone else comes in. So there's a balance of people. It turns out most of our senior people stayed 25 years because they believed in our team. And now everybody retired at once. So that's the problem. We have like 3 or 4 of our senior nurse specialists all retire within 18 months. And it's good and bad. It's
Right.
bad because we're paying the price, but it's a reflection on the program and how they bought into it and how they lasted 25 years not looking for another job. So the other surgeons, Dr. Bakulis, Dr. Farrelly, who are my partners, they're both wonderful surgeons. And you have Dr. Stopek and her Dr. Baer, and Dr. Cohen is the oncologist, Dr. Stessen and Dr. Manny, and I think Dr. Valentine might have just retired, so I don't know if he's still giving radiation. And we have Dr. Bowie and Dr. Houston on the plastic surgery side. So we have a full team of people to help the best we can.
Great. So, and we heard from some of them. Dr. Manny had joined us and explained the great things he's doing. So to really wrap it up, is there anything you could offer the audience and thankfully, although breast cancer is still, there's the mortality factor, but there's the screening factor, and thank God we have it.
Yeah, so we talked about screening, and it's a very good point. It reminds me, so it used to always be self-breast exam, where the thing would be hanging in the shower, and you'd have to do this monthly, and if you didn't lay on the bed and do a full breast exam every month, you felt guilty about it. It's really, I think a lot of that was from the days where mammograms really couldn't see much, and it's not just to rely on the mammogram, but the new wording and the new terminology is breast self-awareness, and I think that should be emphasized. I think it's hard for a woman to do her own breast exam. Some doctors, it's hard for them to do breast exams. So breast self-awareness means being totally aware of yourself and your body and the way it looks and the way it feels on a good day, so that you could recognize something abnormal in the mirror or something you see in your clothing or something abnormal. So I think we're moving away from the breast self-exam because it doesn't really seem to accomplish all that much. But breast self-awareness is extremely important and should never be sacrificed. Sometimes you can see something in the mirror. Sometimes you'll see something in the office, and you just know this person wasn't breast self-aware. So I think that's the new terminology. That doesn't mean we shouldn't be diligent about our own bodies and ourselves, but that's sort of the new emphasis that we're putting on things. And the final word is, if you have something that doesn't seem right to you, this is probably the most important thing, and it's new, and you don't understand it, and the mammogram and ultrasound is negative, ask if you should pursue it further. Don't believe it's all fine if you have a screening mammogram and ultrasound and it's fine, you're good to go. But if there's something new or different, and the tests are negative, and then your doctor thinks you're done, ask, and ask. Because occasionally, you ask me what we see in the office, is sometimes a clinical symptom or complaint was ignored because the x-rays were normal. It still means in all likelihood you don't have a problem. I mean, in the 90 percentile. But there's still a small chance. So if it's something that still worries you, now I'm not talking about a lump where you felt it and then the next month you don't feel it, or a lump that you have trouble finding and there's something. I'm talking about something that you really think is different and new. Do not ignore it. if you're told the mammogram and ultrasound are negative. Pursue it further until you get satisfaction.
You are your own best advocate, and we thank you so much, Chief of Breast Surgery here in Stony Brook, Carol Baldwin Breast Center, Stony Brook Cancer Center, Dr. Brian O'Hay, the great Dr. Brian O'Hay.
Thank you, Pat.
Thank you so much.
Thank you all for coming. Okay, take care. Thanks.